I appreciate it. I am going to share my screen, and this is always the most nerve-wracking part about any presentation is to get the screen right. Uh, hmm, not sure what you guys are seeing because it looks different. There we go.
We can see
Um, can you guys see just the presentation view, or are you seeing the other way?
we're seeing the presenter view.
So you need me to swap it.
Just swap it. Yep.
There we go. Is that better?
Yep, good to go.
All right. And if there's any issues, let me know with the slides or anything. All right, sorry about that. So I'm super excited to talk to everyone today about inequities and access to treatment for substance use disorder. And actually, one of my big areas of clinical interest is opioid use disorder, injection drug use, and healthcare for incarcerated people. So part of the presentation will be focused on this. To talk about the learning objectives today, we're first going to take a little bit of a step back. We're going to just talk about what addiction is as a chronic medical disease. And then we're going to talk about in history the regulations that have affected how we treat patients with substance use disorders today. We're going to talk about how medications for opioid use disorder, which is abbreviated as MOUD throughout the presentation, is important for treatment of opioid use disorder, which I abbreviate as OUD. And I'm a physician, so I deal with medications every day. I'm going to use some analogies as I like talk to my patients about them. But if there's any questions about medications, I'm happy to answer them. And then we're going to briefly hit about some inequities in access to care and some potential avenues for advocacy that you all can use. So first of all, I want to state addiction is a chronic medical disease. And that basically means that individuals that express addiction have to have two things. They have to have a genetic predisposition to develop addiction. Just like people have to have a genetic predisposition to develop high blood pressure, diabetes, or all the other chronic medical diseases that I treat every single day. And then something has to happen in the environment that causes them to express that disease, that genetic predisposition. So a lot of times it's, exposure to substance use, either in their peer groups or their families, different traumas that happen, adverse childhood events. So that then cause this disease to actually be developed and express itself. And what I also want to highlight is that just like any other chronic medical disease, we have very effective evidence-based treatments available. So that's the medications I'm going to talk about later. And so just because somebody is diagnosed with the disease of addiction or opioid use disorder doesn't mean that this is, hopeless. We can treat these diseases very effectively. And what I mean when I talk about addiction as a chronic disease is it basically develops this own drive that takes over everything in a patient's life. And a lot of times, this leads to loss of other things that are so important to us as humans and just causes complete chaos in my patient's life. So they can, not graduate high school because of their substance use, maybe, or get a college degree because of their substance use. It can interfere with employment opportunities, maybe even lead to loss of an opportunity, employment opportunity or a job, loss of relationships with, of course, romantic partners, but then also family members, parents, children, right? A lot of times there is legal consequences that our patients deal with. All of these things that completely derail their life, maybe even like food insecurity, housing insecurity, all of these things. And what I remind my patients of is their entire brain has been affected by this chronic medical disease. So, in the beginning, when they use, they get intoxicated or what we call a high, sometimes on the street. But then, once that effect of the drug wears off, they go into withdrawal. And a lot of times, those symptoms mean that they feel lower or worse than they felt when they started to use. So then their brain becomes preoccupied with the desire and the thought of using again and trying to achieve that feeling of euphoria or high again. So it's this constant cycle of binging, withdrawal, and then preoccupation with using again. And this slide kind of just highlights the different areas of the brain that are affected by that, and that we typically in life use to do other high executive functions every day. And as I said, substance use disorder is a chronic medical disease. And every chronic medical disease will express symptoms. So if somebody has high blood pressure, they might go to their doctor and they might find out, even though they've been taking their blood pressure medication, that their blood pressure is not controlled and they need to add a second medication. Or type diabetes, right? If people go to their doctor, they have their A1C checked, a blood level to see how their diabetes has been controlled. It might not be controlled, and they might require an increase in medication or adding a second medication, more counseling on dietary modifications, things like that. So that's how chronic diseases express symptoms. And similarly, in a substance use disorder, people with a substance use disorder will express symptoms of their disease, even if they're in recovery. And that can mean that they might have cravings for substances or that they will use substances. And that's an expression of the disease. So that's something that we medically expect is going to happen and that then we address, right, and treat, just like in any other chronic medical disease. So somebody having a return to substance use is by no means a moral failing. What I always highlight with all my patients, though, is that this disease is a lot less forgiving than other chronic medical diseases. Sure, for your diabetes, we want you to be at optimal control. But if you're not at control for a few months, you're probably not going to have lethal consequences for it. We have a little bit of time to regulate that. But with substance use, if you are using, anytime you use, you're at high risk of having severe adverse consequences, including getting severe infections, experiencing like traumatic events like car accidents, things like that. And then, of course, also dying, including dying from an overdose. So, this chronic medical disease, unfortunately, is a lot less forgiving than other medical diseases. And that's highlighted here in this graph that I'm sure some of you have seen, and I will show it again in later graphs. But we are in the middle of an overdose crisis that has sharply increased over the last few years with the presence of synthetic fentanyl in the streets. And every year, over 100,000 Americans die from an overdose. And in Kentucky, every 4 hours, somebody dies from an unintentional overdose. So, this is a huge mortality for this chronic medical disease. And as I said, this is a treatable clinical medical disease, and it is a medical emergency that has high morbidity and high mortality. So we all probably know that coronary artery disease or heart disease is the number one cause of death in the United States in general, causes about 610,000 deaths per year. Overdose have risen sharply. And in 2022 and both 2021 and 2022, over 100,000 people died from overdoses in America. And I like to compare that sometimes with motor vehicle accidents because I think that's something that everybody understands as a preventable death that could have been avoided. And when I drive down the highway, a lot of times I see these signs that say, buckle up. This is the number of people who have died in a motor vehicle accident this year in Kentucky, things like that. So there's really a lot of public awareness around this to try to decrease these avoidable deaths. And I wondered to myself what we could do if the same public awareness was attached to opioid use disorder and unintentional overdoses, how we as a public could decrease unintentional overdoses, especially when we think about, for example, as I said, every 4 hours in Kentucky, somebody dies from an unintentional overdose, but about between 40 and 50% of them, another person is present. So if that person had a Narcan or naloxone, the overdose reversal drug available to them, that's a death that could have been avoided. So just some food for thought here. Um, overdose deaths right now, unfortunately, is the leading cause of mortality for people under 50. And it's actually because of that led to a reduction in expected life expectancy in the United States. However, these people aren't just dying because of overdoses. They also have higher rates of dying from untreated infections, so injection-related infections such as osteomyelitis, which is an infection of the bone, endocarditis, which is an infection of the heart, cellulitis, which is a infection of like a lot of times the skin and soft tissues associated with that. So those all can be fatal for these patients. And then also trauma, as I mentioned, car accidents or work accidents is a higher prevalence in people with opioid use disorder, and then also suicide. So now we know it's a chronic medical disease that has a high mortality and morbidity associated with it. But unfortunately, it's highly stigmatized in the medical community. Um, this is a study, a survey study out of Texas, and as was mentioned in the introduction, I'm an internist myself, a hospitalist, and in this study, only 20% of the internists, so my colleagues that were interviewed, felt that they could adequately screen for substance use disorder. And so for me, this is really shocking because as a doctor, if you can't screen for a disease, how are you supposed to diagnose it and treat it, right? Like screening is the first process and or first step in the process of offering treatment. And then 1 out of 3 internists in this survey study thought of substance use disorder as different than other chronic medical diseases. And as I just explained, it really isn't, right? Like we need to recognize it and we need to treat it. And then 1 out of 10 people in this study actually believed that people with a substance use disorder should be punished. So, as you can imagine, for a physician, right, like we want to treat all of our patients open minded with a patient centered approach so that they can have the best, most equitable health outcomes possible. So, if there's doctors thinking that somebody should be punished for their chronic medical disease, that doesn't exactly lead to a good clinician patient relationship. So, even though we have the medical evidence to know that addiction is a chronic medical disease, we know we have treatment available. How come that there is such a stigma in treatment of addiction and especially opioid use disorder? And this is kind of one of my favorite fun facts. It's going back in history and really seeing how regulation around treatment of opioid use disorder has impacted how we still treat opioid use disorder today. And I'm going to take you back to 1914. So over 100 years ago, that's when the Harrison Narcotics Act was passed. And this was done in response to the first US heroin epidemic. And this was an act that imposed a special tax on all persons who, and then I wanted to draw your attention to all the verbs that are used here: produce, import, manufacture, compound, deal in, dispense, sell, distribute, or give away opium or coca leaves, the salts, derivatives, or preparations. So for those of you who have some background, maybe in legal or law or anything like that, that's a very comprehensive language and encompasses a lot of things. And this basically, prior to the Harrison Narcotics Act, there was a lot of physicians that were treating opioid use disorder with other opioids so that patients could be engaged, like have that chaos reduced that I said, that drive in their brain, and engage in a meaningful life in society. But the Harrison Narcotics Act made that illegal. So that fundamentally changed medical practice and really increased stigma towards opioid and cocaine use, but in general, substance use disorder. And the Harrison Narcotics Act was actually then a few years later backed up by a Supreme Court ruling that said it was not in good faith for a physician to treat addiction to opioids with opioids, as I mentioned, was common practice then. So that effectively took away all treatment tools that physicians had at that point. And the Harrison Narcotics Act is still effective. So, um, what the Harrison Narcotics Act really did is it took the treatment of a chronic medical disease of opioid use disorder away from the healthcare providers and turned it over to law enforcement. And this has shackled how we as physicians treat opioid use disorder for over 100 years and has really led to a lot of health inequities, as I will demonstrate. So, just to make you aware, we prescribe buprenorphine, which you might know under the brand name of Suboxone, in an office-based settings. Um, and then there's also another medication called methadone, so I will talk about that. But both of these medications are working on the opioid receptor as full or partial agonists. So, for physicians to prescribe that legally, we actually needed an act of Congress to pass this so that we were not violating the Harrison Narcotics Act. And to me, that's just absolutely mind blowing that there's still a law from 1914 that now still requires um, acts of Congress for us to practice the best evidence-based medicine when we have over 100 years of medical research that are really showing how effective these treatments are. And the government has recognized that this limits the access of patients to care, as I will discuss. So there was actually the Consolidated Appropriations Act of 2023. It was one of the omnibus bills. And as part of that, that special license that physicians had to have to prescribe buprenorphine or Suboxone, the brand name is Suboxone, was removed. So the government has recognized that treatment access is underutilized and that we need to expand the prescriber workforce. And taking away that special license is one of the big steps to increase access to care. And I just also want to point out there's the war on drugs that happened 1971 by President Nixon. So that basically kind of was a direct result of the Harrison Narcotics Act, and it led to increased law enforcement, arrests related to possessions, and then increased length of sentences. And due to the limitations of this presentation for time, I just want to point you to a really good YouTube video. I think the slides will be sent to you so you can watch this. And this is moderated by JC and really highlights how the Black and Latinx community has been affected by the war on drugs and how it has led to severe social determinants of health that impact those communities. So really worth a watch. I think it's about 10 minutes. But as I said, the sentences have increased related to use and possession of substances. And that has led to a significant increase of incarcerations. This is data, I think, from 2021. That shows that we have the largest population of any nation of incarcerated people that are spread out across state prisons, local jails, and then also federal prisons. And in this, if we split it out by race, we see that about 58% of people who are incarcerated are white, 38% of people are Black. So if we look at the patient population of America, we can see that while Black people make up a smaller portion of incarcerated people compared to the percentage they make up of the population, they are overrepresented in our carceral system. And this is partially due to the war on drugs that happened. 93% of people that are currently incarcerated are male. And these are people, as is highlighted in this chart, that come from lower socioeconomic backgrounds. So the slide on the left, or the three graphs on the left here show that incarcerated men, over 50% of them made less than 22,500 in the last year prior to incarceration. So Black people and people from lower socioeconomic backgrounds are overrepresented. And with that, also, people with substance use disorders are overrepresented in the carceral system. About 65% of people meet the DSM-5 criteria. So that's the criteria we use to diagnose substance use disorder for a substance use disorder. And I want to highlight that this says substance use disorder. It doesn't say opioid use disorder. So we don't even know which substance use disorder. We are not even diagnosing what substance use disorder specifically is. This alcohol use disorder, cocaine use disorder, stimulant use disorder, benzo use disorder, opioid use disorder, multiple substance use disorders. And because treatment for all of these substance use disorders differs, right? That would be like saying 65% of them have some sort of chronic medical disease. Well, is it high blood pressure? Is it diabetes? Is it coronary artery disease, right? These all have different treatments. And then additionally, and 20% of them were under the influence of some sort of substance when the crime occurred. So people with substance use disorder are severely overrepresented in the carceral population, but only about 5% of them receive medication for opioid use disorder. So they are severely undertreated for their chronic medical disease. And I will highlight why this is so important when we talk about the medications for opioid use disorder. So that is going through the first learning objective, kind of talking about how the regulations tie in to why we have such limitations on treatment and why we have such a high patient population of patients with substance use disorder who are incarcerated. So I am going to take it with that, and let's talk about medications and why medications are so important as part of the treatment. I showed you this slide before. I just want to remind you, we are in the middle of an overdose crisis, and we have 100,000 people every year dying from overdoses, and a lot of them involve synthetic opioids such as fentanyl. We have 3 FDA-approved medications that are available for the treatment of opioid use disorder. So it's methadone, buprenorphine, which is known under the brand name of Suboxone, Subutex, Sublocade, like all of those you've probably heard before. And then naltrexone, which has a long-acting intramuscular formulation called Vivitrol. So those are the 3 medications. And all 3 medications work slightly differently. So the mu receptor in the brain is what an opioid works on. It's what our natural opioids and endorphins work on, right? We all express the mu receptor, and when things happen that make us happy, it gets activated. Similarly, if we are in pain and we need, like some opioids for pain treatment, they work on that. So methadone is a full agonist, so it completely occupies that receptor. Buprenorphine is a partial agonist, so it partially works on it. And then naltrexone is a blocker, completely blocks it. And I realize that that is kind of medically complicated. And I don't expect you to know the different nuances of this. But I do want to highlight that this means they are not interchangeable. You can't just switch somebody from one medication to another, right? Just like you can't just switch somebody who has type 1 diabetes from insulin to metformin. That person would then, have severe adverse health consequences, including potentially death. Similarly, for medications for opioid use disorder. And how I explain this to my patients, and I am not an electrician, so this is a very basic analogy, but if you have a plug, right, where you plug in your cables or whatever to hook up your appliances. So the plug is your mu receptor. And if you have someone on methadone, they are just able to basically plug in their TV, toaster, whatever, without anything, right? It's a complete full agonist. It completely works. If you have buprenorphine, it's like if you have a converter or something, like if you go into a different country and you need the voltage converted, so you have to plug that in first for it to work. And then naltrexone is a complete blocker. So it's as if the child safety is on the plug. So that means no matter how hard you try to plug something in or stick your finger in there, you're not going to have access to that plug. So that's how the 3 medications work differently. Both methadone and buprenorphine treat cravings for opioids and treat withdrawal. Naltrexone does not treat withdrawal. It has mild evidence of treating cravings, but those studies are from countries where buprenorphine or methadone was not allowed. So, for example, Russia is one of the big countries with these studies, and it's not head-to-head trials in comparison. And now, this is a very important part. Both methadone and buprenorphine reduce all-cause mortality and reduce mortality from opioid overdoses. So these two medications are life-saving for our patients. We do not have that evidence for naltrexone. So both methadone and buprenorphine are mortality reducing. And then for the medicine people here, the FDA approval is slightly different. So a methadone and buprenorphine are approved for the treatment of opioid use disorder, but naltrexone or Vivitrol is approved for relapse prevention. So now that we know that there's the three medications, that they all work slightly differently, let's talk about the mortality. And I think this slide is the most important thing to understand about medications for opioid use disorder. Somebody that has an untreated opioid use disorder has a mortality that's 6 times higher than the general population. So these are often young people at super high risk of dying. So that's the middle bar here. But if these people are started on methadone or buprenorphine, so Suboxone, that mortality goes down to about 1.8 times that. So still elevated compared to the general population, but severely mortality reducing. And when I think in my practice as a physician, I've now been a doctor for almost 10 years. Can't think of any other medication that is so mortality reducing. So, even like things like antibiotic for sepsis and stuff like that, they keep people from dying, but they're not as mortality reducing as these medications for opioid use disorder. However, a lot of our patients struggle to access these medications, as I will highlight going forward. So this is really where the inequities come into this talk. So first, I want to highlight, this is an article from the New England Journal of Medicine that highlights a population model assessing how many people in the United States currently are on medication for opioid use disorder and should be on opioid use disorder. And this article found that less than 10% of people who would benefit from being on medication for opioid use disorder, so severely mortality reducing treatment, currently receive this medication. So that already is, to me, a severe health inequity. Less than 10% of people that would benefit from a medication are on it. And of course, I ask myself, why is that the case? And I think it goes back to some, of the Harrison Narcotics Act and 100 years of stigma against opioid use disorder that then got transferred to medication for opioid use disorder. And that stigma is present in medical providers, in the recovery community, and in society at large. So a lot of times people perceive that someone is only in recovery if they're on nothing at all, which is absolutely not true, right? The chaos of addiction that takes over someone's life is severely reduced when they are on medication like methadone or Suboxone, and they can actually get their life back and like repair those relationships, get a meaningful employment, all of those things that maybe addiction has taken from them, they can gain back with that medication. So this is not trading one drug for another. This is engaging in medical care with a provider who's going to monitor you. And then also, I want to highlight there is some medical professionals out there that refuse to see a patient that's on medication for opioid use disorder. And that's actually illegal. That's a violation of the ADA, the Americans with Disabilities Act. And that will be sent out afterwards in an article. And I'll briefly discuss it at the end of this presentation as well. So, stigma is one reason why our patients don't have access to this medication. Another reason is the location of buprenorphine providers. And as I've mentioned, there used to be a special license to prescribe buprenorphine, the X waiver, that has been eliminated as of the beginning of 2023. This is a map from 2018 from a study that looked at people that had an X waiver or were able to prescribe this mortality reducing medication. And the very, very dark spots that are kind of here, like in the middle, going from Texas up, highlight counties where there was not one single provider who had an X waiver. So this means there was entire counties and states where patients could not even see a doctor or a nurse practitioner or a physician assistant who had a license to prescribe the severely mortality reducing medication. Um, and like when I look at this map, it just blows my mind how many people did not have access to one of the two mortality reducing medications. So when I see this, I ask myself, as a medical community, how did we stand for this? If this was type 1 diabetes and all of these states didn't have a single doctor or provider available that could write a script for insulin, it would be, I think, national headlines. People would be up, and it would be an uproar, right? But for opioid use disorder, we've accepted this for years, that there's these geographical disparities that people don't have access to care. Similarly, switching from geographics to socioeconomic backgrounds, this is a study out, I think it was of, JAMA Psychiatry from 2019 that looked at buprenorphine visits by payer type, and they looked at increases. And as you can see, the big light blue line here highlights that there was a large increase in prescribing of buprenorphine, but mostly in people that were self-pay. And that was despite both mental and health parity legislation and Medicaid expansion facts. There was just a lot of providers and physicians out there that did not accept Medicaid, those type of insurances. And the example they used in this article was what they found out was one half of the physicians in Ohio who were prescribing buprenorphine were accepting of cash only. So there's severe socioeconomic disparities as well. And then they looked at buprenorphine visits by race, and they found that there was a significant increase in prescriptions to patients who identified as white compared to patients who identified as Black or a different race or ethnicity. So racial disparities. And that leads me to another study as well. So this is a study that was published in JAMA Open Network that looked at all the counties and county equivalents in the United States in 2016. And what they found was that highly segregated Black or African American and then Hispanic or Latinx neighborhoods and communities had a higher concentration of facilities that provided methadone as compared to communities that were highly segregated for white people, where there was more providers available that were providing buprenorphine. And I want to be very clear. Both of these medications are good medications that are mortality reducing, right? However, as I highlighted, they're not interchangeable. So there's some people that are going to do really well on methadone, and there's some people that are going to be doing really well on buprenorphine. And people really need to have access to both medications and be able to make an informed healthcare decision and choice about which medication they want. And then in addition, most of you might know, methadone is dosed every single day. So they don't get take homes for the first 90 days. They have to go every single day to get dosed, which is severely limiting for a lot of people's lives, right? You have to have reliable transportation to get there every day. You have to have a job where you can, show up after you get dosed, right? So certain shift work might not be compatible with that. Childcare responsibilities might be interfering with your methadone dosing, all of those things. And then the other thing is, as I said, medication for opioid use disorder, unfortunately, is still highly stigmatized. So when you're standing in line for your methadone out the door, there's usually, everybody knows, right? That's a methadone clinic. Everybody that goes there has an opioid use disorder and is engaging in treatment, which is something we should celebrate. But unfortunately, people still get stigmatized, and just that stigma is a lot of times a deterrent for some of my patients I've experienced, that they don't want to do methadone because they don't want to be seen going to the methadone clinic every single day. So that's why it's so important to highlight which locations have access to which treatment. And then, as I've mentioned, naloxone. So that's an overdose reversal drug. If someone has suffered an opioid overdose, it is administered intranasally. It can be administered through an IV or intramuscularly, but the Narcan kits are all intranasally. And they looked at a study of how this was prescribed to people in the emergency room who presented after an overdose. So these are already people that almost died from opioid use. And they found out that Hispanic or Latinx patients were more likely to receive naloxone compared to white or black patients. However, overall, fewer than half of patients got a prescription. So this is a medication that's covered by insurance, a lot of times covered by grants, and can be handed out for free in a lot of places like the health department, things like that. That people weren't prescribed despite having almost died already from an opioid overdose. Younger people were more likely to receive naloxone, so there's definitely some ageism at play here. And people were more likely to receive naloxone if they were at a large academic center compared to a rural community hospital. So once again, there's geographic disparities at play here. And then, unfortunately, this is a very sad statistic. I've mentioned that overdoses are increasing. However, it is increasing at a large rate in certain minority groups, and the people that have the highest increase in death, a young Black man. So a very sad statistic here from 2022. And as I've mentioned, Kentucky, every 4 hours, there's somebody in Kentucky who dies from an overdose. And about 2/3 of those had an opportunity of intervention before, and about half of them had a bystander present. So I'm going to just lead a plea here for all of you to carry naloxone. I carry it with me everywhere I go. I actually gave some to my husband, and he was able to reverse an unintentional overdose when he was a bystander in a traffic situation. And it took about 10 more minutes after they had administered the Narcan that he was carrying before law enforcement got there and had Narcan. So he did save a life that day, and that could be you too. So I think anybody who knows anybody that's using substances or has a substance use disorder or knows anybody who's prescribed opioids, which I think is all of us, right, should carry Narcan, because you never know when you walk into a gas station and find someone down. And this is just how to administer Narcan. You want to make sure the person is actually unresponsive, right? Like sternal rub them, and then give them the little nasal spray. I have a picture down here at the bottom. It's this white um, adapter, goes in the nose, you squirt it, call 911. It comes with 2 doses. You can give the second dose. Roll them on their side in case they vomit so they don't choke on their own vomit. So it's really easy to do. And if they're down for another reason, like let's say their blood sugar is low or their blood pressure is low, and you give them Narcan, you're not going to cause any harm. So this is a very good thing to carry with you. And yeah, you can get it at a pharmacy. They can run it through your insurance. Kentucky has a standing order where everybody can get naloxone. And I just ran it through my insurance. It was $4. You can get them for free at the health department and at the needle exchange services. And then the Kentucky Harm Reduction Coalition also hands them out. So there's a lot of opportunities to get Narcan. So with that, I'll do a brief summary before I go into the Americans with Disabilities Act. And I am almost done, so we have time for questions. So treatment for substance use disorder in general, especially for opioid use disorder, has been heavily regulated both at a federal and state level, which has led to, rather than having evidence-based treatment approaches in the United States, opioid use disorder has been treated as a moral failing and led to incarceration of large population parts rather than treatment of a chronic medical disease. Unfortunately, there's a lot of stigma present that interferes with evidence-based mortality-reducing care. We know that the two medications, methadone and Suboxone, are significantly mortality-reducing, but extremely underutilized. Less than 10% of people have access to them. And there's significant disparities in access in geographic, socioeconomic, and racial. And unfortunately, Black people, especially young Black men, have the highest increase in overdose deaths. And we talked about how to reverse an overdose with naloxone if we encounter one. With that, I just want to like a brief word for patient advocacy. You will all receive an article that I wrote with a few other faculty here at the University of Kentucky of the Americans with Disabilities Act. People with opioid use disorder are actually considered as having a disability under the Americans with Disabilities Act. So it is illegal to discriminate against people based on their substance use. And it's actually illegal to require patients as a blanket policy to stop their medication for opioid use disorder. Um, so that means a public entity, so for example, a jail or prison, is not allowed to withhold medication for opioid use disorder based on a blanket policy. They would have to have a physician or a clinician individually assess a patient and determine that the risks of medication outweigh the benefits that a patient is getting. So this is how to file an ADA violation if you see one. This is also in the article, and these are avenues where you can file an ADA violation. So if you or somebody you know is on medication for opioid use disorder and has experienced discrimination, that is something that our assistant attorney is very interested in finding out to make sure that all of our people here in Kentucky are not being discriminated against, and so that we can eliminate some of the inequities that are related to substance use disorder treatment. And with that, I just want to acknowledge the Bell Addiction Medicine Scholar Program and the chair, Dr. Michelle Lawfall. And then our addiction consult service here at UK is grant funded, and Dr. Laura Finucchi is the PI for that. And with that, I will take questions. Okay, somebody said yes. What's the shelf life of Narcan? It's usually about 2 years or so. It has an expiration date when you get your Narcan prescription. It has an expiration date. So depending on when you fill it. There recently was a study out there that not they used expired Narcan. It was still potent. Obviously, like if you have the opportunity to exchange it, you do want to make sure that you have some that's not expired. But if you're in a situation you find yourself you only have expired, still use it and hope that it still works. But regularly refill it or like update the prescription. Yep, there's a video you can watch and have sent to your house. Absolutely, there's multiple sites. I can't think of the one right now off the top of my head, but yes. Does he add to court judges? Yes, absolutely. So that is part of the paper that will be sent. The question is if 80, so there was actually a case in Massachusetts against a drug court and it's a settlement with a drug court. And in there, the judge had required of everybody to be on Vivitrol, even if they weren't on any medication before, or to be switched to Vivitrol. Um, and that was deemed to be a violation of the ADA because it was a blanket statement rather than an individualized assessment of the patient's needs. And as part of the settlement, they had said that only clinicians can recommend what medication somebody should be on after an individualized assessment or if they should be on medication, and that it was a violation of the ADA for the drug court personnel to mandate certain type of medication or recommend one over the other. In the beginning of yes, so medication-assisted therapy. So now we say medication for opioid use disorder. There was a time limit for the use of Suboxone and other meds. What's the medical policy for now? For example, should patients who are on Suboxone for a period of time be required to taper off eventually? That's a very good question. And what so the recommendation is a patient should be on a medication for as long as they benefit from it. So what I tell my patient is this is the same as when we start treatment for high blood pressure, right? You have a genetic predisposition that makes you express this disease, and you have something in your environment that happened so that you now are expressing the disease, right? Two things are going on. So we're going to give you medication, and then we're going to see what happens, right? So if you have high blood pressure, I might counsel you on a low salt diet, on maybe some weight changes, exercise increases in exercise, things like that, right? And I'm going to monitor your blood pressure as you follow my recommendations. And there's two scenarios. Either you you follow all my recommendations and your blood pressure responds beautifully, and I'm check it in the office and it goes down, 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 and eventually you can come off of the medication, and that's great. Or there's another scenario where you follow all my recommendations, but you have such a strong genetic predisposition for high blood pressure that you have to be on this medication for the rest of your life to get benefit from it. And both pathways are okay. And when we start out treatment, I don't know which pathway you're going to fall in, right? Similarly to opioid use disorder. So we're going to start Suboxone. You're going to work on things like, all the things that addiction took for you, whatever that was, right? Get your GED, get your college degree, get a job that you want, resolve your legal issues, maybe get custody of your children, repair those relationships. And then once your life has stabilized, we'll assess. And it might be that we can taper you off of the medication. Or it might be that you have such a strong genetic predisposition for opioid use disorder that you need to be on Suboxone for the rest of your life, and both are okay. It's a safe medication and it doesn't really have any like serious long-term side effects, right? I think the biggest thing people complain about is like dry mouth and the taste of it, and then constipation. So we just manage the side effects. So both pathways are okay. And I don't know where you're going to be when we start out. How does someone come off of Suboxone? So I think that goes kind of with that. Typically, tapers last weeks to months to years. So what we typically do is we decrease the dose in the outpatient setting slowly, and then we see the patients and assess them, right? And we ask them, are you having cravings? Are you having withdrawal symptoms? We're going to get a urine drug screen to see if there's any other substances present. Because as I mentioned, the expression of the disease is substance use, and substance use can be deadly. So we want to make sure, are you using, or are there any stressors that maybe give you triggers, right? Are you having dreams about substance use? A lot of times that's the first way people express cravings. So we assess that, and depending on that, we either go over a slow taper, or we might not be able to taper off. There is injections that you can give. There's two different types of injections, Brixadi and Sublocade. Brixadi is very new. Sublocade's been around for several years. We give it once a month. So sometimes people taper with the injections so that we give it every other month and then every third month, space them out like that. That's another way to taper. But it's very important that these tapers are after patient's life has been stabilized and under the close supervision of a medical professional who is assessing for expressions of the symptom. Is it true that it's causing dental problems? Um, Yes, so that's the dry mouth that I kind of like alluded to. So that's one of the side effects. That's a side effect of all opioids that they can so good oral hygiene is really, really important. So it's not really the Suboxone that's causing it. It is like more of a side effect, and we can manage that really with good dental care, regular teeth brushing, good dental follow-ups. And I will say uncontrolled substance use disorder also causes a lot of dental issues. So I think if you compare the two, it's, treatment with Suboxone is still a lot safer for teeth. Opinion on Sublocade. I think Sublocade is a great medication. So for those that might not be familiar, it's an extended release injectable that people get about once a month. Um, I think it's a good medication for a lot of patients because, first of all, they don't have to remember to take the medication every day. They don't have to make the decision to take the medication every day, right? Sometimes for people, it's easier if they make the decision once and then stick with the plan for recovery. They don't have like the risk of losing their medication or taking too little or too much. Sometimes people are concerned about diversion, so giving the medication to someone other than the intended patient. So for that, Sublocade is really good. Um, Sometimes people, have transportation issues. They can't come to clinic once a week to get their Suboxone script. Initially, you have to come once a week. So then Sublocade is a good option there. There's people that maybe are unhoused or have other social determinants of health that lead them to not being able to take a medication every day or high risk for losing medication. But I think overall, I think it's a very good medication. I think it works just as well as the by mouth product. And when we look at studies compared for follow-up, engagement in care, negative urine drug screens for other opioids, so it works just as well. And then I think we just need to practice an individualized approach to see which patient would benefit from which medication the best. Does what does CCPHC mean?
Chronic or complex physical health condition.
So I am not sure because I'm not familiar with that term. So I'm not sure the answer to that question. I apologize. Maybe somebody else in
I don't
the,
actually know the answer to that question either, Jennifer, and I think someone else may have also posed that question. So we can certainly look into that and provide you with an updated response via email.
yeah, but it is protected under the Americans with Disabilities Act in Kentucky. So I don't know if those two are related. um, so why would someone want to be on medication for opioid use disorder after long-term jail time? That's a great question. So for opioid use disorder, there's withdrawal, right? And usually the acute withdrawal, right, when people are vomiting or sick, lasts a few days. But then there's this phase of chronic withdrawal that can last month to years. And that's that persistent preoccupation in the brain of wanting to use substances like this. And, when I showed the slide of the brain circuit, that anticipation of next substance use, that can last and that can be dominating and take over someone's life and someone's entire way of thinking. So in order to treat those cravings, those persistent cravings, we would start medication for opioid use disorder. And then the other thing, after long-term jail time, people lose their tolerance to opioids. So they will leave the jail and they will use opioids. And this is actually the highest risk time of people dying from an overdose. There's a study out of Oregon that showed that the 2 weeks after release from jail, someone was 12.7 times higher of dying from an unintentional overdose than the rest of the population. And incarceration itself is a social determinant of health. And this is a high risk for people from dying. So I think anybody that's incarcerated should be screened for substance use disorder. And if they're diagnosed with an opioid use disorder, should be offered all three medications and counseled on which, how they work, which one might be best for their choice. And then they should be treated while they're incarcerated. And then at the time of discharge from jail, should be linked to a medical provider in the community to continue treatment. And they should receive naloxone. So they have that available. It's actually the highest risk population for overdose. There are many
Dr.
drugs.
Sal,
Oh, I think someone said
I'm
there's many
sorry to
drugs available. Yes, there is many drugs available, but even if people are using in jail, a lot of times they're not using the same amount or same potency as on that's available on the street. Sorry, go ahead,
Dr.
Dr.
Sal,
Allen.
thank you so much. It's 3 o'clock. I just want to be respectful of your time and of those on the call. I really appreciate everything that you shared today, and also appreciate all of the questions that we had. We had some really great
We did.
questions. We will be sure to share Dr. Sal's slides, and we'll be sure to share the presentation, the recording as well. Thank you all so much for joining, Dr. Sal. Thank you again. John, if there are any on the call that want to hear more information about the CE process, John is going to quickly cover some details around that. So if you want to stick around and hear exactly what the CE process is going to look like, just stay on for a couple more minutes and John will provide that information to you. But for those that need to run, thank you all. And thank you again, Dr. Self.
Thank you. Thank you, everyone, for coming and the great questions. I enjoyed the discussion.
Absolutely. Thank you, Dr. Allen. So I'm going to do a quick run through on the CEUs. So to receive CEU credit for today's training, attendees must have attended at least 90% of the training. After November 22nd, a link will be sent, and it will be sent so you can access the session evaluation and the certificate. You'll be able to access your certificate at the following link. Only those who attended at least 90% of the session will be eligible for a certificate. Attendees that attend must log into MTS with their email address used to register. Attendees must complete the session evaluation to access their certificate. Attendees are responsible for printing their own certificates. If you have any questions, please submit those questions to kyschoolvirtual@ky.gov. And finally, I do want to highlight upcoming sessions that will be occurring. And so on December 6th, we'll have Dr. Alana Tackett, and her presentation is entitled Youth Use of Emerging Products, Vapes, Flavors, and Oral Nicotine. And that will occur from 11 a.m. to 12 p.m. Then on January 11th, we'll be joined by James Campbell, and his presentation is titled Worlds Apart, What Works in Adolescent Treatment and Why. And the following links are here as well, and will be available for registration to attend these sessions as well. So thank you, everyone.